Alrighty, last one, week 9, reproductive pharmacology. Alrighty, so STDs, prevention of STDs, wear your raincoat when you go out in the rain. So when you are treating an STD, if it is a gonococcal infection, gonorrhea, we're going to be using a dual antibiotic therapy using ceftriaxone and zithromax because there's been progressively more resistance that's built up over time to gonococcal infections. We also want to recommend not having any sex for 7 to 10 days until the infection is able to be controlled. After that, we're going to retest for reinfection or for cure 3 months or 3 weeks or 3 months after therapy. For chlamydial infections, again, no sex for 7 to 10 days while we are taking our Zithromax. And once again, retest for reinfection and cure 3 weeks to 3 months after infection or therapy. For syphilis, we're going to be using our fabulous penicillin G with a dose that's based upon what stage of the 4 or 5 stages a person is in syphilis. 4 or 5 being whether you're going by the book or by some other source. With pregnancy, it's a little more complicated, and we just really don't want the kid to have syphilis. So we're going to be trying to cure the mother and treat the mother as well while she's preggo, and hopefully they don't get syphilis congenitally. Herpes, 1 or 2, we'll be taking acyclovir, given PO, and this is going to be okay to give during pregnancy. We're going to educate patients on using condoms, especially when they are having a breakout to reduce transmission. And then we're going to have, if they're symptomatic and giving birth, then we're going to do a cesarean section as delivery for the purpose of preventing transmission of HSV to the neonate. HPV infections, we're going to educate our patients on doing regular Pap exams because this is a great way to ensure that we catch cervical cancer quickly. Encourage our patients to always get the HPV vaccine. Hopefully we can get that approved for a much younger population so that we can get this prior to sexual activity, though we can do it after sexual activity has already started as well because there are multiple strains of HPV. Right now it's tested for those between ages 11 to 26, but there's really not any harm in giving it early. It doesn't lead to sex, and there hasn't seemed to be any issues physiologically with giving it early. Estrogen and progesterone. So estradiol is our female estrogen. The ovary produces it, and so does the placenta. The testes in males also produce some of it, or it's kind of converted from testosterone. It will be helpful towards providing primary and secondary sex characteristics, the reproductive tract development and ductal growth in breasts, helps to increase bone mass by reducing resorption of calcium from the bones into the blood, and it helps to increase HDL and lower LDL. And it also can affect blood coagulation by either promoting or inhibiting coagulation, and that's important later on in regards to the risks of blood clots because it's basically the estradiol, going out of whack in the body. It has plenty of adverse effects, both from an endogenous perspective and when taken exogenously, such as out of the body. Endometrial hyperplasia and cancer are distinct problems. So, let's see here, okay, so if taken alone by postmenopausal women, then we'll have endometrial hyperplasia and cancer. All right, now my brain's back on track. So if you take estrogen by itself, and with postmenopausal women, they can experience endometrial hyperplasia and cancer. If you take estrogens and progestins together, then the risk of cancer dramatically reduces. That's the primary purpose of taking progesterone with estrogen. When taken both together, unfortunately, that also increases the risk of breast cancer. So it's kind of an either one. Which one do you prefer to have? Greater risk of having. Estrogen also promotes ovarian cancer, cardiovascular disease in the form of thromboembolisms, cardiovascular disease, and myocardial infarctions. Nausea is a distinct issue as well, and is the most common side effect. And luckily, it will subside, or usually subsides, with use. And if we take estrogen when pregnant, then it may lead to fetal abnormalities. So, outside of contraception, the main purpose of taking estradiol is going to be for hormone replacement therapy, especially for women during menopause, to help with those really awful symptoms that can occur. We've got also the potential to treat acne or PCOS with estrogen. We can be given orally, which is the most normal route, but it can also be given transdermally, intravaginally for taking care of some of those menopausal symptoms, and parenterally. Progesterone is also another hormone produced by the ovary and placenta, and is also minimally converted via testosterone in males. So we will have an increase in levels of progesterone during the luteal phase, which is after the ovary has popped out a little egg and the egg goes down to the uterus. This is going to be produced primarily by the corpus luteum. So originally it's from the follicular cells are producing progesterone, but then after that egg gets popped out, then it becomes that corpus luteum that originally had the egg that produces progesterone until either the woman gets pregnant, in which case the corpus luteum continues to produce progesterone, or the body's like, well, there's no sperm, and then it flushes everything out and the corpus luteum atrophies and goes away. Progesterone is also important for ductal growth in breast tissue, primarily to get it really ready for lactation, and is a major hormone in pregnancy and lactation. Couldn't find anything about the endogenous steroids in the book, nor inflammation. Some adverse effects, we've got ovarian cysts, so that can occur a lot, especially with women who are using progesterone for birth control. There's a higher risk of ovarian cysts from that. Breast cancer is a potential issue. We don't know why. Depression, breast tenderness, pregnancy can be teratogenic, so a lot of the same stuff as estrogen in some ways. So outside of contraception, then of course we're going to be using it as replacement hormone therapy. Along with estrogen, we aren't going to be giving progesterone on its own except for as a contraceptive. It can also be given for dysfunctional uterine bleeding because progesterone will promote the regularity of endometrial breakdown and the cycle of menstruation and ovulation. We can also help with premature birth prevention because progesterone helps to relax uterine smooth muscle. And then it can also be used for endometrial cancer and hyperplasia in that it's countering the proliferative effects of estrogen. So estrogen is going to, as we saw back up here, endometrial hyperplasia and cancer, estradiol, estrogen, can promote that. So we want to try to not promote that by giving progesterone to prevent endometrial cancer and hyperplasia. Same routes of administration as estrogen. The physiologic doses of estrogen are given to control the signs and symptoms of menopause, whereas the physiologic doses of progesterone are to counterbalance the estrogen-mediated stimulation of the endometrium. So the estrogen does a lot of good stuff, it does some bad stuff too, and we give the progesterone to try to counteract the bad stuff. Um, but unfortunately, hormone replacement therapy, because of the significant side effects that can occur, use of them have gone way downhill, which is good from the perspective of being able to reduce the number of people who are having serious issues with taking this medication. But that also leaves a number of people who are having to just plain old suffer through um, menopause. So the benefits of taking estrogen is that we get our, or y'all's, vasomotor symptom relief, which is a fancy word for or term for hot flashes. Um, Estrogen is also responsible for maintaining the urethra and the vagina, the integrity of the tissues there. And without having estrogen, then women are at risk of urogenital atrophy. So what that's going to do is we're going to have issues with, for example, urge incontinence, urinary frequency, urethritis, UTIs, and then vaginal dryness, vaginal pain with intercourse, and vaginal infection via like a bacteria, what's that word? Vaginal bacteria. But God, I forgot that word. Oh, whatever. Um, Bacterial and fungal infections. And for that, to decrease the urogenital atrophy, we can also be using the transdermal preparation. Estrogen also can promote protection against osteoporosis and fracture because estrogen inhibits bone resorption, with bone resorption being that it pulls calcium out of the bones and into the blood. And then giving both estrogen and progesterone can help prevent colorectal cancer and reduce the risk for reduce the risk of uterine cancer. Of course, that comes with risks. The main thing being that we have the potential for significant cardiovascular effects. Estrogen has been shown to have impacts on coagulation. So if we give it as hormone therapy, then there's a potential for risks or clots. So that can then result in strokes, DVTs, PEs, maybe MIs. Estrogen by itself has the potential of developing endometrial and ovarian cancer, and then also developing gallbladder stones, cholecystitis. Giving both of them together, there's still the potential for MI, and it seems actually that it may be according to the book, a stronger effect compared to giving estrogen by itself. So that's a little bit concerning. There's also that increased risk of stroke or clot risk. And instead of endometrial and ovarian cancer, given estrogen and progesterone just increases the cancer risk for breast cancer. And then still also cholecystitis. Oh, hands-on stuff. Okay. Androgens, testosterone. These are produced minimally by the ovary and adrenal cortex in the women. There's a different androgen that's produced. The androgen produced by the adrenal cortex, I forgot the term for it. It's in the previous, not the previous, I think it was endocrine. Yeah. Endocrine slides. It's a long, funky word. And in men, it's just straight up testosterone from the testes and some other stuff from the adrenal cortex. But the testes, testosterone tend to overcome that or overpower it. So the primary use of testosterone is in men who have androgen deficiency. The adverse effects, virilization, which is developing masculine features. In men, that may not be a bad thing. In women, that might not be a bad thing, but it might more likely than not be a bad thing to them. It also will help to increase libido, and unfortunately, there's a potential, especially if you abuse it, of developing gynecomastia. We can also develop hepatotoxicity through way of cholestatic hepatitis and have symptoms like nausea, anorexia, and fatigue. There's also the potential for abusing testosterone via way of anabolic steroids, such as in bodybuilding or sports and performance. So combined contraceptive methods. So birth control, we know what it does and why it does that and why that's good. I don't have a clue what's being said here. I don't know what that means. Choice of birth control comes down to determining what's effective, which ones have which safety issues, and really which one's up to the patient's personal preference. Oral contraceptives will inhibit ovulation and will inhibit or alter the cervical mucus. So we're going to keep them eggs from really popping out of that ovary or them ovaries, and we're going to change the mucus in the cervix to prevent it from being as capable of allowing an egg to really get in there and fester and do its all things. So we can come either with a progesterone-only form or a combination form of estrogen and progestin, with the combination being the most common type that we would see in the field that people are going to use. And of course, it comes with a list of adverse effects. Normally, though, the total risks associated with oral contraceptives are less than the total risks of pregnancy because you got an alien growing inside of you. So we have thromboembolism. This is going to be for the same reason why we see that there's issues with hormone replacement therapy. Estrogen tends to have issues with, and progesterone too to some extent, have issues with affecting blood coagulation. So there's a risk for thromboembolism. Hypertension is a potential adverse effect because they will be increasing serum angiotensin, which is responsible for vasoconstriction and aldosterone levels, which will then increase the volume of fluid in our system. It can also worsen cancers, for example, breast cancer, but it will not create breast cancer. Glucose intolerance can become an issue. Abnormal uterine bleeding, in that there's actually not any bleeding, and for many people I'd imagine that would actually be a positive thing, with the only downside being that you can't guarantee you're not pregnant. And then nausea, breast tenderness, agitation, weight gain, common side effects of oral contraceptives. The risk for thromboembolism is going to be greater for those who are smokers over the age of 35 or suffer migraines with an aura. There are some very favorable effects or uses of oral contraceptives. It can decrease the risk of benign breast disease and acne, which is great, because it keeps the hormones from fluctuating as much. It kind of keeps them at a more consistent level. It can decrease the symptoms of polycystic ovarian syndrome because we are not promoting the ovaries from working as hard as they normally do, and which is part of what contributes towards the development of cysts. Decreases in uterine cramping, calming down them periods. It decreases the bleeding amount and duration, which can help with anemia. And they can also improve the PMS symptoms. Unfortunately, there are a number of side effects or interactions that can occur from taking oral contraceptives. So these meds, rifampin, the anti-tubercular medication, the ritonavir, I'm going to go with that one, for HIV, anti-epileptics, St. John's wort. Just don't anyone take St. John's wort. There's too many problems. All of these will decrease the effectiveness of oral contraceptives. And then oral contraceptives will also cause a decrease in warfarin, a decrease in insulin, a decrease in oral hypoglycemics, an increase in theophylline, an increase in TCAs, tricyclic antidepressants, and an increase in diazepam. So gotta keep these in consideration. In general, oral contraceptives, you're just better off going with something else if you can, because these have You have to be on these perfectly for them to work. You got to be on the exact same time frame every single day. There's got to be a darn good reason that you're going with taking oral contraceptives, because there are others that just simply work better and insurance will still cover them. There's also then the transdermal contraceptive patch, this little doohickey there, and the NuvaRing, the vaginal contraceptive ring. These are great from the perspective that they will increase adherence and therefore increase the practical benefit, or the practical, what's the word they used? Practical, I just dropped it, whatever. How well they work, because people are actually using them. The problem with the pills is people oftentimes don't actually definitely stay on it. If you stay on it, they have a great success rate. If you don't, I think if you go on the average of what most people actually do, instead of it being like 0.2% failure rate, it becomes an 8% failure rate. I think maybe it's 2% to 8%. I don't know. So with these, generally you have it on for, I don't know why it says 1 month. It's normally, I think, 3 weeks, and then you come off of it for 1 week to have your period, and then you go back on it. Some people I've heard don't. They just stay on it the entire time. I have no idea whether that's safe. But otherwise, similar adverse effects as oral contraceptives. Plan B is both a wonderful and a horrible medication. It's wonderful from the perspective that it is a great opportunity to say, whoops. I was trying to remember that Britney Spears song, but I can't remember it. Oops, it did again. No, yeah, not whoops, it's oops. Oops, it did again. So you forgot your raincoat outside or something, and you are like, I need to make sure I'm not getting preggers. So you take it, and then you have a miserable 3 days. That's where the horrible part comes in. It just sucks. You just end up flushing like your entire uterus out your hoo-ha. So this is going to prevent or delay ovulation. Used for rape or failed method, no contraceptive used. Had too fun of a night at the bar, then didn't realize, oh my gosh, I didn't use a condom. So Plan B is the most popular type. Ella is another kind that's also effective. So this is a progestin tablet. This is a progesterone agonist. So this will encourage the production of progesterone. This one you get to take within 5 days, which is a lot better than the 3 days. Sometimes it takes some time to think about it and be like, I don't know if I really want to or not. But in both cases, it's always better to take it sooner rather than later. Same stuff otherwise. LARCs are the best that we can go for at this point. Nexplanon is, I believe actually that according to the book, had the best success rate. The only problem with Nexplanon is that it has systemic hormones, so you're not going to have symptoms limited to just the reproductive organs. There's a potential you're going to have more weight gain. I don't remember what other symptoms there are, so I'm just going to say symptoms in general. There's also the depot shot, and intrauterine devices or systems, which are amazing. Let's see here. Okay, yeah, so I think that's the copper one. Don't go for that one if you have heavy bleeding, or you might be heavy bleeding, because that will just make it worse. The Mirena and the Skyla are amazing. Yeah, so let's see here. Adverse effects, there is a decrease in embolisms and clotting risks, which is really, really good. For the implant and IUDs, there are the risks that, that surround the procedural implantation of the device. In other words, it's going to friggin' hurt. You're shoving something up your uterus and your cervix. It's going to bloody well hurt. And oftentimes, it's going to really get wonky with your cycle, making it so that you are bleeding for weeks on end, or perhaps you go a really long time without bleeding. You go 2 weeks between your period, you go 8 weeks between your period, and you can't figure out when the heck your period's coming or going. Lots of problems. Those who are lucky end up having next to or reaching amenorrhea. Weight gain with Depo-Provera because of the systemic hormone becomes a problem. And then we can get anemia and severe uterine cramping because copper IUD tends to make the period cycle worse symptom-wise. So you gotta really go for it only if you are already light on your periods. But the benefit is that there's no hormones involved. It is simply by way of the copper acting locally in the uterus. We also have options of things like spermicides and barrier devices. Don't use spermicides on their own. They're not effective. Use them with a barrier device. Condoms are mostly great, but don't believe that they can actually prevent all STIs because there are other areas of epithelium that are able to mix, and juices mix and stuff, and everything gets everywhere, and all of a sudden you have an STI. Also our diaphragms and cervical caps. Vasectomy is something. I don't know what vasectomy is. I know what a vasectomy is, but I can't see what that is supposed to say there. It's supposed to be pretty good, but it actually is not that much better. I think it's actually a little bit better than getting tubes tied, and it's only a little bit better than a LARC. So if you're thinking which one should I go with, if you're sick and tired of having the woman take all the brunt of preventing childbirth or pregnancy, then make the dude go get the vasectomy. But if you're like, I can go either way, I might have kids later, then get the IUD. They're going to be about the same exact level of effectiveness. And that's it.